you need resources that can design and conduct research. You need people who are familiar with statistics and analysis of outcomes while the trial is ongoing. And of course, you need established clinical trial sites. And this is, one of the many things that is not as well established in many developing countries. Though things are changing for Pakistan, we are increasingly seeing sites that have dedicated research centers, but it is not, an established practice in many teaching hospitals as well as research centers. So with this in mind, I'll just end briefly by sharing how we were able to participate in the WHO COVID-19 solidarity trial. I'll just very briefly share the uniqueness of that particular protocol. So ideally, it takes RCTs months and sometimes even years to develop. And there was a need for speed and quality in this particular situation. So WHO had actually reduced the time to design this particular protocol by more than 80%. And this was literally, this protocol was developed within a matter of days. They also put a lot of thought to how they can make sure that already overburdened and taxed healthcare systems can participate in this trial without landing up in unnecessary paperwork. So there was minimum documentation requirement in this particular trial. And a single large multinational trial means that we will be able to generate evidence that small single center studies cannot ever hope to have. So this is a model that perhaps should be used even in a non-outbreak situation, because it's the delays in research planning and the presence of too many requirements that often prohibits LMIC centers to participate in large-scale trials. So this trial was announced towards the end of March 2020 by the WHO director. It was actually one of our internal medicine residents, Dr. Shahzeb Khan, who first thought of the idea of Shaukat Khanum and hence Pakistan joining this trial. He discussed this with one of our ID physicians, who then discussed this with us, the research team. And the WHO ICTRP portal, the registry which has all these trials registered, had actually crashed at that time because of the influx of COVID-related traffic on that website. So we contacted someone who was managing ICTRP portal from WHO end, and he was the one who linked us to the R&D blueprint unit who's managing this trial. So access to information as well as backup sources of access are very important to make sure that the information reaches where it's needed. We then had to find sites and see how logistics are available, at least some basic logistics are available with those who would be participating with us in this trial from Pakistan. And here I would like to comment that even though requirements for logistics were limited in this particular study, but we did end up selecting places that had at least some basic structure of conducting clinical trials, which meant that many institutes and hospitals who were seeing a lot of COVID patients could not qualify for this. So while it's important to remember that it's perfectly acceptable to start with what you have at the beginning, it's also important to develop capacity as you go along. We all are familiar with how a trial is set up. You need approvals, you need to develop site protocols, you need to train people and establish finances. When I end, my colleague Farah would talk a little bit about how we tried and streamlined the ethics approvals process, at least at the institutional level. And I'm hopeful that the National Bioethics Committee chairperson would also join us today, and some members from our regulatory body who can also comment on how they instituted a rapid review process at their end to streamline ethics and regulatory approvals. I'll end by this final comment that it's important that we plan for the future while participating in this collaborative research. So I'm sure we'll learn how to learn while doing during an outbreak situation. But it's also important that we enhance our research capacity and evolve from participants to leaders of research. And this is also an unprecedented opportunity to form clinical trials consortia that sites from Pakistan can organize, which are currently lacking in a country like ours. I'll end here, and I'll ask my colleague to share her brief comments related to ethics review, and then we can move on to our next panelist.
Thank you, Mariam. So yes, epidemics, one after the other, makes us think if we are ready uh, to respond for effective and efficient response for such an outbreak as we are dealing right now. An efficient and effective infectious disease outbreak, our response to this must integrate research as part of the outbreak response, which would require a balance between resources and the time allocated to immediate management as well as to research. Global health emergencies, by their nature, are challenging environments in which one is to conduct research. We need to find ways in which all stakeholders, including governments, political leadership, scientists, researchers, as well as regulatory bodies and ethics review bodies, can act in best synchronized way. So substantial ethical issues have already been investigated. However, there are countries which have hosted outbreaks and they have also hosted research during the pandemic situations. And they have highlighted the need of ethics preparedness. From the previous work, there are certain recommendations which I would like to take the opportunity to share with you. So we would need well-defined guidelines and ideally a standard operating procedure at a national level to facilitate research at the national level, as well as we would need mechanism for multi-country emergency ethical consultation to save our precious time. We would need procedures for communication between key stakeholders that would involve the government, the political leaderships, the regulatory bodies, and the researchers. That is very important. We should try to engage the community. This is very important because this is the research about them. We should always remember to get back to the community as soon as possible, because ultimately this research should benefit them. And as Mariam has already talked about this, we need to find ways to support emergency planning, including securing robust health and health research systems, given the vital importance of properly resourced preparedness between the emergencies, so we are better prepared to deal with the next emergency. So with this, I would conclude my thoughts, and I believe we can move forward to our panelists. So, okay. So our first panelist would be Dr. Salma Abbas. She is infectious disease specialist at Shaukat Khana Memorial Cancer Hospital and Research Center. So I would invite her to share her thoughts with us. So Dr. Salma. Okay. So let us open her slides. So Dr. Salma has been heavily involved in providing us the best practices and the guidelines for dealing with COVID at the institutional level as well as at the national level. So we are grateful that during these times she has spared time for this webinar. So Dr. Salma Abbas would also be joined by one of our colleagues soon. So yeah, this one. So we can very well imagine that how much our infectious diseases specialists, our researchers, they are heavily engaged in during these times. So Dr. Salma would start. Dr. Salma Abbas, please.
Hi, everyone. Can you hear me?
Yes.
Okay. I'm Salma Abbas. Thank you so much for the opportunity to speak here today on COVID-19 treatment. Since this is a vast topic and we are limited as far as time is concerned, I'll dive right in. So I'm going to start with a disclaimer about COVID-19 treatment. As we know that this virus recently came into the picture, so there are currently no approved anti-infectives for treatment. There is no consensus on which drugs to use. The therapies that are currently prescribed are either done so in an investigational capacity or being used off-label. The current existing evidence that we have is either small studies, case series, or case reports. The trials that we have some design flaws. There's conflicting evidence as far as whether to use these drugs or not. A lot of studies do not have comparison groups, so these are serious limitations in the literature. To date, 580 randomized controlled trials have been registered on clinicaltrials.gov to determine which treatment will be the best for COVID-19. A very important thing to note is that none of the studies that are currently available have been done in Southeast Asia. And Dr. Mariam already highlighted the gaps in the literature and how we're planning on bridging those. So then what are the treatments that are currently being used? So it's literally the kitchen sink that is being thrown at these patients at the moment. And I've lost count. So there's hydroxychloroquine, chloroquine, coconut oil or juice, ivermectin, plasma treatment. There's tocilizumab, there's remdesivir, there's lopinavir, ritonavir, there's montelukast, there's arbidol, favipiravir, herbal remedies. There's some magic pills, which are some garlic pills, and no treatment at all. So where do we stand as far as treatment of COVID-19 in Pakistan is concerned? I will now be reviewing the treatment modalities that are available and are being used in Pakistan in the interest of time. So starting with chloroquine or hydroxychloroquine. So what is the mode of action or the rationale of use? So it raises the pH of endosomes and it also prevents viral entry into the cells. What are the key toxicities? There's risk of QTC prolongation and retinal toxicity. And looking at the existing literature. So yes, the use of chloroquine is supported in vitro data. I reviewed 2 RCTs and there were some serious biases in these studies. These had mostly looked at patients with mild and moderate disease. The endpoint, and as of right now, we really want to know how those sick patients should be treated. Now, endpoints that some of these studies try to look at were not reported in the final manuscripts. Again, some studies support the use of chloroquine and hydroxychloroquine and others oppose it. One of these 2 trials was actually prematurely terminated. So that was also a very concerning thing. Again, case series and case reports have also reported QTC prolongation, which is a serious concern. So what is the verdict as far as chloroquine or hydroxychloroquine is used? Is that the current evidence is inconclusive and we need further studies to elucidate the role of hydroxychloroquine or chloroquine for treating COVID-19. Another treatment option that is being considered is combining chloroquine or hydroxychloroquine with azithromycin. So the rationale for doing that is a possible synergy between these 2 drugs and the QTC prolongations. So both of these groups cause QTC prolongation and the effect is augmented when you co-administer these 2 drugs. So what is the existing evidence on these? So I came across 4 observational studies limited by small sample size. Important to note that they had actually looked at intermediary outcomes as endpoints, such as viral clearance and decreased viral load. And they had omitted important clinical outcomes such as mortality, the rate of progression to ARDS, and the need for mechanical ventilation. So that's a very serious flaw in the study designs. Again, QTC prolongation was described in about 10% of these patients. So that's, again, a serious concern. Um, there's a French study that is being quoted everywhere these days, and is being used as the basis for treating patients with a combination of hydroxychloroquine and azithromycin. It's important to note that there were only 20 patients in that study who received hydroxychloroquine, and of those, only 6 received azithromycin. So you can imagine that this sample size was very small, and we really can't conclude anything based on that data. So what is the verdict? Is that important outcomes were not evaluated in these studies, and we need further studies. Moving on to lopinavir ritonavir, this is actually a drug that is used for HIV. This is a viral protease inhibitor, and the key toxicities, again, are QTC prolongation, hepatotoxicity, and GI side effects. Looking at the existing literature, so this is one medication for which a nicely designed randomized controlled trial has been conducted. A total of 199 patients were enrolled in the study, and the allocation was 1:1 to lopinavir ritonavir versus supportive treatment only. The study found no difference between the two groups in terms of mortality and no difference in terms of viral decay. However, they saw a small difference in failure in clinical improvement, which was lower in the lopinavir ritonavir group. Some critics of this study say that perhaps lopinavir ritonavir was given too late to some patients while their symptoms had been going on for 10 to 14 days. So maybe we don't know if earlier administration would have changed the outcomes. So what is the verdict on this? Existing evidence does not support the use of lopinavir ritonavir, but we do need further studies to further elucidate the role of lopinavir ritonavir, including a study of whether early administration will have a different outcome. Moving on to tocilizumab. It's an IL-6 receptor inhibitor, may have a role in cytokine storm, which is implicated in severe COVID-19 infection. What are the key toxicities? So it's really important to see that this is a highly toxic drug. It can cause immunosuppression, hypersensitivity reactions, hepatotoxicity, cytopenias, hepatitis B and TB reactivation, and intestinal perforation. So I came across 2 case series to see, if this would be effective in COVID-19. Again, limited by small sample size, there were no control groups. The dosing was inconsistent, ranging from 80 milligrams per day to 480 milligrams a day. The number of doses, again, was inconsistent. Some received 1 dose, some received 3, and inconsistently combined with other anti-inflammatories and agents such as steroids. So there was no uniformity in any of the patients that were described. In one of these, there were 15 patients. 7 of them were critically ill, 6 were seriously ill, 2 were moderately ill. Of the critically ill patients, 3 patients died. However, they had received only a single dose, and 10 patients improved overall. So the verdict is, again, there's inconclusive evidence, and we do need further studies. Moving on to convalescent plasma. So what is the rationale for doing this? Is that it contains antibodies. It's obtained from patients who've recovered from COVID-19, and this will be used as passive immunization. Key toxicities are allergic reactions. Again, there are small case series available on this. The sample sizes are very small. They have been, convalescent plasma has been co-administered with other drugs like lopinavir, ritonavir, and interferon. So you don't know if the benefit that is seen is due to convalescent plasma or due to the other agents that are seen. Again, we do need further studies on this. And last but not the least, remdesivir. It seems to be a promising agent, currently not available in Pakistan, which is why I've labeled it with an asterisk. It's an RNA-dependent RNA polymerase inhibitor. Key toxicities are GI side effects and hepatotoxicities. A recent study came out describing a case series with 53 patients enrolled, and 63% improved. There was 13% mortality. However, very important to note that there was no comparison group, but this seems to be a promising therapy. There's currently no role for prophylaxis, and it's not recommended because even as treatment agents, we don't know if these anti-infectives are going to be beneficial. So, we can't make recommendations about prophylaxis at this point. So what's the bottom line? The current evidence can help us generate hypotheses, but it's inconclusive. We need further studies, especially in our region, because genetics and other factors also come into play when we look at infections and responses to clinical treatments. The drugs that I just went over may be considered for use in patients who have moderate or severe disease where no contraindications exist, and it's best to use these in trial settings. Thank you. I would just like to add a last line, is that prevention is always better than cure. So please practice and stick to good cough etiquette, good hand hygiene practices, and social distancing. Thank you.
Thank you, Dr. Salma. Thank you for sharing a comprehensive review of the evidence. That was helpful. Next, I would take opportunity to invite Dr. Raza. Dr. is physician infectious diseases. And he has been in a leading role at our institution in providing the guidelines on how to deal with COVID. So, so in a few minutes, you would be able to see the slides made by Dr. Raza, and so we are sharing the slides with you. I hope you are able to see.
I think yes.
So I think it's just taking a few moments while we are opening the slides of Dr. Raza. So I must say, the infectious diseases physicians and the researchers, they are the heroes of this pandemic, and we are relying heavily on them in providing us the guidelines. So I hope you can see the new slideshow. So Dr. Raza, please.
Thank you, Dr. Farah. Good morning and good afternoon. I'm Dr. Raza, and I'm one of the infectious disease consultant at Shaukat Khanum Hospital, Lahore. As this is my hospital. Briefly, I will discuss the overview of virus spread, modes of prevention, and prevention for general public and for healthcare workers, and what we are doing at our center. So we all know by now that this virus is spread from person to person by coughing and sneezing, and it's a basically droplet infection, and also by contact. And when we come into contact with contaminated surfaces or objects, our hands, they get contaminated, and when we touch our face, eyes, or nose, the virus can be transmitted to us and can lead to infection. So how can we prevent actually from getting infection? So most important thing is avoid exposure. And second important thing is vaccine. So unfortunately, we do not have any vaccine available for this infection at the moment. And we'll discuss how we can avoid exposure. So since December 2019, when this virus was first diagnosed, and when we knew more about this virus, different countries, they have started making vaccines for this virus, and every country has different role and different vaccines. So these are the various trials which I came across while searching for vaccine trials on clinical trials .gov. So most of these trials are from China and USA as well. And most of these trials are in phase 1 and phase 2 trials. None of the trials are in phase 3, and they are still recruiting volunteers, and study results are not available at the moment. So these are the two news from Pakistan, that from our papers, that UK to start human trials for COVID-19 vaccine from tomorrow. I believe this is from the Oxford Center, and Chinese pharmaceutical company offered Pakistan to conduct a clinical trial for vaccine. So this is from today's newspaper. How can we prevent general public, and what's the what our role should be to educate general public is that hand hygiene is most important, especially in countries like Pakistan, India, Bangladesh, where other infections or foodborne illnesses or other infections are transmitted. So hand hygiene is a key factor. So in this disease, we should encourage the general public to wash a hand with soap and water for at least 20 seconds. Alternatively, we can use a hand sanitizer, which has at least 60% of alcohol. And as I mentioned earlier, that we should avoid touching eyes, nose, and mouth if our hands are contaminated or if they are not washed. WHO has a list of situations before and after which we should wash our hands, and we all know about that. Then cough etiquette is very important as well, just like hand hygiene, and we should advise all of healthcare workers and general public that we should cover our cough or sneeze with a tissue or with bent elbow as shown. And after that, we should throw the used tissue in trash and perform hand hygiene, either by washing or by using hand sanitizer. Another important thing, because it's a droplet infection, is that we should avoid close contact with people who are sick, and especially when there is community outbreak, we should maintain social distancing and maintain at least a distance of at least 2 meters or 6 feet. And if somebody is unwell or has mild symptoms, he should stay at home and should come to any healthcare facility only if they have severe symptoms like shortness of breath. Recently, there has been a debate that whether universal masking should be done or not. WHO initially issued an interim guideline on 6th of April, and they suggested that for general public, masks are, any form of masks are not recommended. But recently, CDC recommended masking for general public as well, but again, for general public, they didn't recommend medical masks. They did not recommend surgical masks or N95 masks. They recommended cloth face mask is sufficient. The reason behind that is that it will not prevent you or the person who is wearing the mask from getting infection, but it will prevent others, because whenever we cough or sneeze, the droplets will not spread and will not infect other people. So that's the rationale behind these masks. And the reason is that many studies have shown that there is asymptomatic transmission of this virus, and that's why they are recommending that we should use universal masking, and especially in healthcare setting as well. We should use surgical masks whenever we are going into any clinical area, whether there is COVID area or not. And then cleaning and disinfection, we all know that we should clean and disinfect frequently touch surface like doorknobs, countertops, computers, electric devices, etc. In healthcare settings, we should follow standard precautions. And this is a sign from our hospital, which displays standard precautions, which include hand hygiene, use of gloves when required, proper sharp disposal, clinical waste as appropriate in the designated baskets or bins, and cough etiquettes. So we displayed this sign at the doors of all the rooms in our hospital, all the patients' room actually. So we should follow these standard precautions. And these are the signs which we follow for contact precaution, droplet precaution, and airborne precaution. We all know that contact precaution means that we should wear gloves and gown, and droplet precaution, we should use surgical mask and N95 respirator for airborne precautions. For COVID, for any suspected or confirmed COVID-19 patient, we are using, just like any other country or as recommended by WHO, we are using standard precautions, droplet precautions, and contact precautions, plus we are using face shield or goggles. And suspected or confirmed patient with aerosol generating procedure, we are recommending standard precautions, contact precautions, along with airborne precautions, where we are recommending N95 mask and of course face shield or goggles. This is the PPE recommendation for our center, and I believe every hospital has its own PPE recommendation based on the PPE supplies and clinical areas. At the end, I would like to emphasize that proper sequencing of donning and doffing is very important, because most of the healthcare workers, if you're not following the proper sequencing of removing the PPE, they can get infected. So this is very important in the current outbreak situation. Thank you.
Thank you so much, Dr. On, for sharing the updates in the precautions for COVID-19. So now I would invite Dr. Rumina Kazi. She's molecular biologist and section head of molecular pathology lab at Shaukat Khanum Hospital. She will discuss the challenges related to diagnosis during an outbreak situation. She has also extended her expertise and help for setting up National Reference Lab, and we believe her experience would be relevant and useful to other lower middle income countries. So Dr. Rumina, let me open your slides.
I don't have slides. Hello, everybody.
Right.
So
Great.
yeah,
Dr.
yeah.
Rumina, please.
So because there is no literature in setting up these COVID-related pandemic labs, therefore I have no slides, but to share my experience in setting up the COVID testing lab at Shaukat Khanum Hospital. So it's like Mariam said initially, it's very unprecedented times for everybody. And we also went through the same pain in setting up the lab. But before sharing my experiences for setting up the COVID-19 testing lab at Shaukat Khanum Hospital, I would add here that my lab at Shaukat Khanum Hospital is not a true representative of the labs in Pakistan, because it is a very well-equipped lab. We have all the equipment, automation. We already perform many molecular tests for oncology, for infectious diseases, for prognostication, for diagnostics, for therapy-related response, for transplant patients, and so many of them. So we have many things in place, yet we had to go through many problems when we were setting up the COVID-19 testing lab. The first and the most important issue that we faced was procurement. Of course, when we learned about COVID-19 infection in China, Wuhan, China, at the end of December, that's where I started thinking of it as a routine diagnostic test to launch here at Shaukat Khanum. But then very quickly, I learned that it has become epidemic in China, and we need to now establish this as it may lead to pandemic, and therefore we started thinking on those lines. So for normal routine, instead of thinking of normal routine testing, I started thinking of having a lab where we can deal with epidemic or pandemic. So for that, we had to do a few things, and the most important thing was planning. So it was initially in the first week of January when we learned about this, we started thinking of the kits for COVID-19 testing. And because China was very quick in sequencing the viral genome and putting them, that was nice of them that they were sharing their data, and therefore many companies were using those primers to make their kits. So the kits, we ordered kits from UK, and then we got some kits from National Institute of Health as well in the beginning of February. So while we ordered the procurement of kits and other accessories required for performing these tests, we started planning. The planning was how to train our staff, because staffing was the issue. The molecular staff could run these tests, but then they were not trained on manual extractions, RNA extractions on that bench. Also, we had limited staff in the lab. Therefore, we had to train research associates from, for example, basic science department, lab technologists from other departments within pathology department. So we had to plan all that. In addition to that, we had to start looking into guidelines and SOPs, like standard operating procedures. And in that, we had to look into operational procedures, like where we will receive the sample receiving area, the PPEs, now where to get PPEs, because as you all know that PPEs were in shortage worldwide. And so we had to really be very smartly, we had to use it smartly. And we had to give them a guideline and how to use the proper PPE, because this was infectious agent more so than others that we are already doing in the lab, like influenza, etc. So we had to give them guidelines. Then we had to train our lab technologists for the safety procedures. So we gave them safety lectures. We had these teaching clinics for them. And this is all we were doing while we were waiting for the kits. Then we had to change. I mean, the main problem that we had was, because we had our routine testing done, we had to stop that and convert one of the labs into COVID testing area. So for that, then we had to relocate the resources. And that was a major issue, because we had to borrow things from, for example, our neighbor lab was basic sciences lab. We had to relocate many of their, for example, real-time PCR machine, their, thermal cyclers, their hot plates, and so whatever was required to establish a COVID testing lab, we borrowed from them. Then we borrowed many things. For example, we were ready to perform about 300 tests per day. And that was after going through the procedures and going through the training of all the technologists, research associates, etc. So then we were told that we need to jack up the testing capacity. So by first week of February, we got the kits and we started working on the testing. Now, because it was new and we did not have any positive controls, because first thing in our lab is when we launch the test, we do validations. So it was very difficult for us to do validations because there was nothing to validate it with against. Luckily, when our kits from UK arrived, we got these kits from National Institute of Health. And so I was happy that now we have 2 kits. And as per CAP, College of American Pathologists recommendation, we can run one sample with 2 different methodologies. And if the answer is the same, then that means your answer is correct. So this is what we did. We ran samples that initially we started getting at SKM, Shaukat Khanum Hospital. We started running one sample on 2 different kits. And if the results were same, we were reporting those samples out. So that was initially our way of validating the kits or the samples. Then later on, we changed, when we looked into our capacity, we were told to increase the capacity from 300 samples, testing samples per day to more than that, because that by then, by March, because it was on 11th March, WHO said that it is pandemic. And by around that time, we got a lot of quarantine samples from people that returned from Iran. So we got about thousands of samples from them, from different camps, quarantine camps. So that was the main issue when we faced, because we were not ready for that large number of samples. So in that, the trained personnel from initially when we trained all these, about 20 people we trained, that helped us a lot. Then as I said, we converted basic science lab. One of the lab we took from them, and we converted that also into additional COVID testing areas. So we had 2 COVID testing areas with all these personnel ready to start extraction. It was a task force, a huge force that we were doing it. And so the validations, as I said, is expensive. It needs funding, and our hospital was very supportive, because of which we could establish the COVID-19 testing facility within a week. So we actually, what else we did? I think, yes, the most important thing that we faced, the issue that we faced, was the shortage of supplies. The most important one was swabs and VTM. You know, VTM is viral transport medium that you need to get the sample and the swabs. So what we did was we started making VTM in the lab. So I mentioned that we have very well-equipped lab. We have cytogenetics as well. And that became handy, because in cytogenetics, we have all sterile components, sterile materials. So we used their sterile, like PBS buffer and fetal bovine serum and antibiotics that is required for VTM making. We made that VTM in-house, and we started assembling them and sending them to different locations, collection centers for sample collection. So this is how we faced, but then we were calm. We did not panic. We were calm, planned. And the most important thing here is the teamwork, that we teamed up with other labs, with other departments, and the hospital was fully supportive. And therefore we established this COVID testing facility, and we performed these testing with 3 shifts, like day and night, for 24 hours. We had to be in the lab for some time, for 24 hours. And the help that we extended to the government is that we performed their samples, thousands of their samples, for free. And when when we realized that there are many samples coming up and we cannot do really single testing, we started working on pooling. And now with pooling, we can perform from 4,000 per test, automation and manual together. We can perform about 20,000 tests per day, and that is in 24 hours. So that's what we have achieved. And I think in the end, I would just say that if anybody can have the ability, but if you have the will to do, so we have the ability, we have the capacity, and we have the commitment to take on this immense challenge. Thank you.
Thank you, Dr. Rumina. This was an amazing story on how you have enhanced the capacity of a lab in an LMIC. So we are excited now that we would be able to hear voices from other countries as well. So now I would take opportunity to invite Dr. Yatin Mehta. He's chairman of the Institute of Critical Care and Anesthesiology at Medanta Hospital in India. It would be great if he can cover how new interventions for critical care of COVID-19 patients are being implemented in India, its associated challenges and research gaps highlighted by this situation for critical care in COVID in India. So Dr. Yatin Mehta, so we're looking forward to hear from you. And you have 10 minutes for your presentation, sir. Dr. Yatin, yes, thank you for unmuting your mic.
Matthew? Good afternoon. Bring you greetings from India. Just trying to put my slides on. Okay, you can see the slides?
Yes, we can hear
All
you.
right. Okay, good afternoon. Uh, this is my hospital, Medanta Medicity. It's a 1,200 bedded facility, private hospital outside outskirts of Delhi. We have 200 ICU beds and 100 HDU beds. So this is how the story began in India. On 24th of March, they locked down the whole country of 1.3 billion people, and pretty effectively, I would say. And this is yesterday's statistics. We have almost 20,000 confirmed cases and with about 3% mortality. And unfortunately, like Pakistan also, this is increasing every day. And this is how in the recent times, from April, the government has started acting on the thing. The advisories have been issued, webinars are organized, guidelines are issued, SOPs are formed for whatever procedures are required, and directors from the ministry have gone to all the states, and accordingly, the follow-up is done. And there is a tele-survey also. And there is a major awareness drive through every TV channel, through every newspaper, so everyone is aware of what is happening with COVID-19. What the government did is they divided, every district has been divided into hotspots, non-hotspots district with reported cases, and completely green zones. The hotspots have been sealed completely, where you cannot go out and you cannot go in. Only the supplies of essential items like food and groceries and medicines is allowed. So the district hospitals, healthcare facilities have been divided into COVID care centers. This is for very mild cases. Patients, some monitoring is done, but the patient just has respiratory symptoms of mild fever. Then there are COVID health centers for moderate cases who require oxygen therapy, but not advanced therapy. And there's designated COVID hospitals where even critical care cases with ventilator support can be handled. And these are the SOPs and guidelines and training material, which is available in several languages to everyone. So how to prevent the infection, how to bar medical waste, how to segregate these patients, how to triage these patients, what are the things which you require, what PPEs you require, everything for professionals as well as public is available on the website of the ministry. And there are various courses in different languages available for these all these measures, from prevention to management and to ICU management and to discharge criteria, when to do what tests, because PCR facilities are limited everywhere, including the Western world. So in which patients to do and so on. From yesterday, a day before onwards, every patient who comes into my hospital, we do a COVID testing. We have a ward where we isolate them prior to awaiting the result, and only then they can mix with the green zone of the hospital. For confirmed cases, we have separate ICU and separate floors. So separate ICU for confirmed cases, separate ICU for suspected cases, and separate ward for both those categories. Therapy, I think part of it has been covered. So these are the ministry guidelines again. So basically, they still we are following the hydroxychloroquine and the azithromycin combination for about 7 to 10 days. Now, there's several recent publications which the previous speaker has talked about, and 2 days back the other publications that have come in, which are negative findings of the hydroxychloroquine. So I think at the moment the recommendations are quite weak, and these are likely to be revised. In fact, one of our young doctors in Guwahati, Assam, which is north east of India, he died because he was in both combination, and he was taking some heart medication, probably because of ventricular arrhythmias. For some patients who have other comorbidities, particularly uncontrolled diabetes, which is very common in this part of the world, elderly people, immunocompromised patients, and so on, we use lopinavir and tenofovir because that's the only retroviral available here. Remdesivir, again, like Pakistan, is not available, but I'm sure it is going to be introduced soon for the trial, which we talked about. So for prophylaxis, again, the national guidelines, they do recommend hydroxychloroquine for up to 7 weeks, and for people who are in close contact with known patients or their family members. This was the guidelines which we published just this month in the Indian Journal of Critical Care Medicine on position statement for critical care of COVID-19 patients. This is based on evidence, or whatever evidence was available, because most of the recommendations, even if you see in the SSC guidelines or ESIC guidelines, they are all based on weak evidence. So that's what it is. And this was position statement was covering the preparedness of the ICUs, staff and institutional capacity, training of healthcare workers, triaging and resource allocation, communication with these people, logistics and capacity, diagnostics, infection control and BMW, treatment strategies, and post-ICU care. So this group was divided into all these categories, and then we did the research and review of literature and basis guidelines. Quickly digressing, because I'm in this group, probably I'm the only clinician, so I can only talk about medical care. So we had a personal experience of more than 1.5 months back when 18 Italian tourists actually landed up in India as a tourist, in a tourist bus with an Italian guide, and their doctor was turned out to be positive. So 15 of them were gifted to us by the government, because obviously they wanted to be these people good care to be taken off. So they're from Jaipur, which is in Rajasthan. They were transported to us, and all were positive at that point of time. So with the Indian Council of Medical Research, we started this investigation, and this was more of an epidemiological investigation. So we did this test on these people from here, all over, including their guide. So index patients was a physician by profession. They reached New Delhi on 21st of February. He tested positive on 29th of February. So he was probably, he had a little bit of sore throat before he left Italy. So maybe he was in the incubation period. And out of remaining 24, 15 patients tested positive on 3rd of March. Total attack rate was 65%, and median age was 69 years. These were quite senior citizens. And median duration of stay was 19 days, which was much longer than what normal ICU patient stays at. And the viral clearance was at 18 days. That's also fairly long. So 6 patients, at 66%, had no symptoms or minimal symptoms. 1 patient was severely affected, and 2 patients were critical. 2/3 of these patients were hypertensives. So 3 patients were severely or critically ill. They all received lopinavir and ritonavir. 1 patient also did receive oseltamivir, and another patient received on a compassionate ground tocilizumab. Actually, we have a randomized controlled trial, which we are the leaders on tocilizumab for cytokine storm treatment. And mortality was 2 patients died. 1 was in Jaipur, and 1 was with us. So 11% mortality. And this was the thankful Italians who had gone back to Italy, and the Italian ambassador sent me 2 nice bottles of wine to thank you. Okay. Then we have a research to the Indian Council of Medical Research going on convalescent plasma. So we are also a part of that. We just started that. Initial results, as I think has been told, are quite convincing, but we need obviously a randomized trial to conclude the multi-center trial. So hopefully within, as one speaker has already said, that most of these trials, they go through the IRB pretty fast. Yesterday, we had an IRB meeting, and this is all on the Zoom, and within 2 hours, you fast track all the clearance. So that is what is happening, and that is what you'll see the results pretty soon in a few months' time. Solidarity trial, already Pakistan is participating, your hospital is participating. We also are part of this. Again, there are several weaknesses in the solidarity trial, because After the trial has been initiated, the weaknesses in hydroxychloroquine therapy have come about. So it may be detriment to actually the outcome of the study. But anyway, we are a part of the solidarity trial. And so what we need to do as a research community? Well, we need to look at the natural history. There may be genetic variations in the response to COVID-19 infection, which we need to probably maybe study. Environmental research is also required. Epidemiological studies will come about. Clinical characterization and management, infection prevention and control of the healthcare workers. Resources are limited, not only in our part of the world, but if you look at the US, they're completely swamped. I talked to a friend of mine in New York State, and they were reusing their N95 masks. They had shortages of PPE. So this problem may hit us hard if the things explode. Vaccine is coming first today. I think it was the first day of Oxford vaccine trial, human trials. So I'm sure we all will participate soon in these activities. Number of cases, well, you can see this is where we are at the moment. But if the cases increase exponentially, it is going to be a disaster for us. And this is what the projected cases are. So by the end of May, 31st of May, almost India would get almost 1 million patients. We have about 7.7 million beds we do have. We have about 40,000 ICU beds already ready. We are made ready for the disaster, but we will require about 70,000 beds. We have about 100,000 doctors and 2 billion nurses ready for this. But this may not be sufficient if the exponential curve goes up to what I showed you in the previous slide. And this is what our distribution of beds per 1,000 persons are. And you can see some parts of India have good number of beds, but some of parts of India are not so good. So this is going to be a difficult challenge for all of us in this part of the world. So a challenge is immense. The most pressing challenge is that there are currently no real therapeutics and no specific tests which are easy to do, rapid point of care tests. We must have a rigorous approach to find our own solutions. There's a global imperative for research, and which we also should be a part of, and not as a leftover of the research findings. A coordinated and multidisciplinary approach is needed, and we must learn as much as possible and as quickly as possible. So I thank you for your attention.
Thank you. Thank you, Dr. Yatin, Mehta. This was great to learn about the position statement of India as well as your personal experience. So thank you very much for sharing this. Now I would take the opportunity to invite Dr. Aliya Naheed, who is scientist and head of Initiative for Non-Communicable Diseases in the Health Systems and Population Studies Division of Dhaka, Bangladesh. We would appreciate if Dr. Aliya could share the COVID management perspective from Bangladesh, specifically from a public health point of view, with the focus on role of health systems management in epidemics and the challenges associated with public health policy making and surveillance programs for epidemics in LMICs. So Dr. Aliya Naheed, I hope you can hear us. And
thank you, Dr. Mariam. Do you hear me?
yes, we can hear you, and I hope others can also hear you.
Thank you very much. And before I start, I would like to check whether you can see my slides. Do you see my slides?
Yeah. Yeah, we can see these now.
Okay, good. Thank you very much to the Global Health Network for inviting me to this wonderful webinar, and Dr. Mariam for inviting me. So this is basically a different kind of talk. You already have heard from our colleagues in India and Pakistan a great deal of clinical aspects and how these countries are doing. So this will be a sort of mix of a little bit of both, and what you have already presented. So it may be repetitions. I apologize for that. So I would like to just first give you an overview of the case detection so far, what kind of management has been in place for epidemic, in response to this epidemic and what challenges the country is facing at the moment. And from that understanding, I would like to give my own perspective about the challenges in public health policymaking, particularly in the low and middle income countries in South Asian region. So speaking about Bangladesh, the first case was officially declared on March 8, 2020, which is far later than when the first case of Wuhan was reported. So the left-hand side graph shows the day by day increase in the numbers, and you can see a very steep rise after April 5, and that was because of the detection facilities. In the beginning, we had only one central laboratory run by the government who had tested all the samples coming from different parts of the country. And over time, the country was able to expand the facilities for testing. Now this is being increasing up to 21 center. So you can see altogether till over the last 45 days, we have detected about 3,772 cases. Our recovery rate is pretty poor, like 2.4%, and fatality rate is higher than the recovery rate that we have observed so far. So in terms of management, so we would think about both the case detection, public health measures, and case management. So it would be nice to have a surveillance system in place for early detection and containment, but we don't have that at the moment, particularly an active surveillance system. This is sort of self-reporting of the suspected cases by the patients or the families when they come up with some symptoms. And those cases are reported through over a hotline number that is designated by the central laboratory. So when these calls are made to those centers, a physician assesses the condition of a patient or person who called that number and decides who is a suspected case and should have a sample collected. And those samples are collected by a health technologist, sending them to the individual's house and brought back to the central laboratory for testing. Altogether, 21 laboratories are functioning at the country at the moment, and there is a concentration of most of the labs in the Dhaka city. And we are following, of course, RT-PCR test that has been carried out in other places using nasopharyngeal samples. So what public health measures are in place at the moment? So our strategy is that when a lab confirmed cases is identified, the case is sent to home quarantine if it is a mild to moderate severity. So home quarantine is more encouraged over institutional quarantine, but those who cannot afford home quarantine because of the lack of space or lack of caregiver or resistance in the family to stay with a patient, lab confirmed patient, they are encouraged to use the institution. So after that, the government authority at the local level actually start contact tracing and identifies if and test those cases in the family or in the neighbor who came into contact of the person. And when there are more cases, the household, of course, for the case when identified in a household, the household is locked down. But there are more cases identified in the neighborhood, the whole area is locked down. But we find a lot of death cases reported without having a lab confirmation. When someone reports a death case of suspected COVID, the similar procedure is taken care of, like groups come from the laboratory for testing and then confirm whether it is a COVID case or no. So what we did as a general public health measure is when after 8th March, we didn't do much of the activities, but on 26th of March, we announced the general holiday, and it was extended at different phases, and now it is effective up to 5th of May. So during this period, so there is mandatory closure of all kinds of institutions like offices, schools, universities, and only essential service facilities are open, such as hospitals, bank at the limited work hour. And there is a lot of banning done, such as gathering on the road or anywhere is prohibited, and in particular in a mosque, people are discouraged to gather there and pray at home. The social media, print media, electronic media are actually extensively promoting the personal hygiene, social distancing, and other measures to motivate people to stay at home and follow through the home quarantine and isolation when somebody is diagnosed as a case positive. So there are enforcement by the law enforcement agency for limiting movement within the community and across borders, irrespective of having a case identified as a COVID or no. But there's a case management protocol for treating the cases in the hospital. There are designated more than 10 hospitals who are taking care of the confirmed cases. And there are 22 other different guidelines that are followed through. And this is developed in collaboration with World Health Organization, and basically a generic protocol for that has been recommended by WHO follow through. The only thing that we should note here that we don't have any specific regimen for treatment, but providing supportive care and a recommendation for ICU support whenever necessary. But there is a huge challenge while imposing the public health measures. On the left-hand side upper corner of the photo, you can see this is actually a general market in a rural community. So these markets are sitting every day, even in the suburb and city areas. So people actually gather there almost on a everyday basis to have their grocery done. When this announcement of the declaration of general holidays was done, hundreds and thousands of people actually went to different stations to go to their homes and some people went their vacation to the beaches. So there is no point of, a holiday, which was basically meant for limiting people's movement and promoting stay-at-home order. And we have seen that there are situations when people actually organize mass prayer to get mercy of the Almighty, to get relief from the COVID situation. And we have seen a lot of funeral done in a large scale. So all these things, all these three pictures shows that although there are a stay order at home in place and there are law enforcement, people are not necessarily motivated or clearly understanding the fear of having the infection and the need of staying home. But these public health measures also gave rise to another humanitarian crisis, that is, the lockdown actually forced the people with low income stay at home, and they didn't have any source of income. And a lot of people, even government workers, shopkeepers who actually were living on their daily wage, they actually lost their jobs, and people did not even get their salaries, even in private sectors. So it created a big chaos, and their demonstration on the road for demanding their pending wages. And now what is happening that the business communities are trying to push lifting of the lockdown. So if we want to draw your attention to this graph, you can see there is a very low line of the cases until April 5, and we have started picking up cases after 26th March. For two reasons. First, you can see there are a lot of exposure, interaction at the mass level, and home quarantine stay home order was not very effective. And also we were also establishing many labs, like we shifted from 1 to 21 lab supports, and we got a lot of cases. Then we found actually had a better understanding what is the infection rate. And as a result, the cases of this epidemic, the cases of COVID had spread all over the country. Dhaka has been the epicenter, and in the middle, the darkest area. And the neighboring cities have been affected, more predominantly than other distant districts. But what we found in common that all these cases actually contracted the disease because of their contact with an active case or their contact with someone who actually returned from Italy or US or some other countries which is heavily infected with COVID. So if we look at the picture and try to compare with our neighbors, India and Pakistan, what we see that if you compare with India, like Bangladesh has picked up its point of rise much earlier than India on the left-hand side that the graph shows. But if we look at the comparison with the Pakistan, the right-hand side upper corner slide, so it shows the number of increasing rates is it's a little bit lower than the Pakistan. And if we try to understand how we were doing in terms of our services to our cases and how they are recovering, if we compare all these three slides, looking at the red zones and green zones, red zones is the active cases under treatment, and green zones are cases who have recovered from the illness, we will see a very small fraction of the patients in Bangladesh are recovering from illness. And it is much, the number is higher in Pakistan and India in terms of number. But when you look at the rate of recovery, the rate was very low and death rate was higher than the recovery rate. So what we felt that what were the challenges that posed this situation of epidemic? So as from the Republican point of view, there may be many other reasons, many reasons that we are learning. But on the top of everything, we felt very strongly that these countries like Bangladesh, they don't have an early warning system in place. So even it is hard to believe that our first case was identified at 8th March. That means circulation didn't happen before that. We have seen many pneumonia cases, atypical pneumonia cases being admitted through the period of January to March this year, which was much higher, 14% higher than the previous years. So probably these viruses were circulating in the community, but we couldn't pick them at the early level. And when the epidemic hit the country, it was very apparent there is very low preparedness, probably due to lack of capacity. And of course, there is no essential policy in place for addressing a pandemic at the moment. But during the epidemic, so we have found reporting is very limited for various reasons. There are limited lab facilities. But we also have found that people don't want to report because they feel stigmatized and they find they are abandoned by their neighbors and people fear to communicate with them. And when we are reporting, we are not always reporting suspected cases. We are only reporting the lab confirmed cases. So thus, the report we have got is basically underreported data set we are getting. So we don't actually, what is the magnitude of the burden and what is the magnitude of the case fatality in these communities. And I believe it is difficult in Bangladesh, in any country, what is the most difficult, home quarantine. Putting people locked down in their homes and areas. And the largest difficulty that we all face is tracking the contact, which is absolutely impossible to identify that contact. And this is why those people who came in contact of a positive case, they have freedom to go anywhere because the lockdown and quarantine is not being adhered to, and they infect a lot of people. On the other hand, we also found that in the service delivery systems, as like other countries, we have limited protection equipment. And in the beginning, it created a lot of resistance among the health providers because of fear, and now the supplies are improved. But we have got a lot of doctors and health workers infected, and it is concerning that already we have a limited health workforce, and the number of functional doctors and nurses are diminishing every day, and this is a challenge. But interestingly, there are a couple of task force built, but public health specialists are underrepresented, and I don't say they are empowered either. So the clinicians are often represented in these public health task forces and guiding the health policies. So there may be a reason why we're not being able to give much stronger and stricter advocacy to the government. This pandemic actually. Hello.
Aliya ji, can I interrupt you? So you have taken your time. So we would request you if you could wrap up your presentation in next 1 minute. We would be grateful.
Right.
Thank you.
So What I see, that projection at the country level epidemic is not necessarily based on the local data. So there's a scope of research to do mathematical modeling using data, but data is not open at the moment. So this is a challenge. But there are collateral damage, as I mentioned before, that other humanitarian crises, emergencies are rising, and lack of coordination across ministries are inhibiting us for planning an exit route of this lockdown, how we come up to a normal pace of life. This has not been discussed at the moment. One thing very important to observe, that our demography is very different than Western countries. The vulnerable groups are different, and we really need to understand what the risk factors we are not actually looking through. I think there's a problem with intra-South Asia. And our capacity in the health systems is not assessed as yet, and plans of effective management and containment of transmission is not being done in a very scientific way, but as an ad hoc basis. This is a problem. And of course, more resources are being diverted to clinical care and not to public health measure. That is another concern issue. But although COVID brings us all the bad experiences and memories, it will remain in our life for a long time. But probably this is also bringing some good things. This is the time when people are being able to spend with family, and family values are being uplifted. I think this is a wonderful thing. And I think this is the first time, at least in many countries, that people were more careful about the personal hygiene. So this is on a more positive note, that this virus is forcing people to change their behavior. And this virus also have shown that these are the weak people, ill people who have low immunity, they are affected more. So having healthy life, active living, it may be more promoted through these. This is an opportunity for public health physicians. Of course, treatment regimens are being under trial and vaccines under trial. Probably we will see a good horizon, bright horizon at the end of the tunnel. But after all these things, we come up with this dark day. We also need to understand, probably you have moved very fast in your life and probably forgot to take care of many things. So we, the public health specialists, need to put our caution and in the right direction, and direct the government how to respond in the future to prevent it in the next wave of COVID. Thank you very much.
Thank you very much. Thank you for sharing the public health interventions and the challenges. It sounds very familiar to Pakistan. And thank you very much for ending at the bright note. Thank you. Now I would request Dr. Mahesh Maskey, who is Executive Chief for the Nepal Public Health Foundation in Kathmandu, Nepal. We would request him to share perspective from Nepal, specifically about generation of epidemiological evidence for health policy formulation in disease outbreak, given his extensive experience in this field. So Dr. Mahesh, we're looking forward to hear you. And sir, you have 10 minutes for your presentation. So Dr. Mahesh. Right, and you would need to unmute your mic as well. So, Dr. Mahesh, I believe you can hear us. You would need to unmute your mic and great, yes.
So where's my slide, please? Or you'll do the slide for me?
Would you like Nicole to put up your slide, Dr. Mahesh, or would you like
please.
yourself?
I mean, I can do it. If you can show it in the screen.
Yeah, if Nicole puts it up on the screen, then only she can navigate it. So if you have it in front of you, you can use that. Okay, Nicole has put it up. She can navigate it for you.
Okay, all right. So greetings from Nepal. A very good afternoon to you all. And this is my first slide, and this is the most important slide. And you'll see that it captures the present situation of Nepal. And has been about 40,000 tests, both PCR and rapid diagnostic test. And the total infected people, test positives are 45. And if you, it is not shown here properly, but if you compare it with other South Asian countries and also some of the Western countries, the ratio per million of the test and the case per test seems to be quite high in Nepal. And interestingly, you'll see the one red zone is here, which the story I'll tell you about that a little bit later. But in Nepal, there is only 45 cases so far. Next slide, please. Okay, this slide, it shows the total case, the red one, and which is 45. And the other one are the new cases. So you can see that actually, this is not 24. We wanted to give a 1 week interval to each. So therefore, the graph looks like this. But the first case was identified in 24th January. And then after 2 months, then another case was detected. And after that, it slowly increased, and we have got now cumulative 45. But if you look at the new cases, the pattern is like this, and we still have to see how it progresses. And the recent rise in the case, there's a story about that, the red zone, which I've showed in the map. Next slide, please. Okay, here I put a comparison within the South Asian countries. And in that, I have also put Kerala, because Kerala is one of the red line is a leading example of how within India also is making a very good progress. So the India and Pakistan and even Bangladesh are quite in the upward, this thing is, their peak has not been attained as such, it seems. Bhutan is doing very well, and Maldives has gone down, but still is taking up. And Nepal is in that situation, which I've already shown you. Next slide, please. Next slide. Okay, this one is for the provinces of India and also China surrounding Nepal. So in Tibet, one case has appeared and it then got better. So we didn't have a problem from there. But the provinces that are around Nepal seems to be still going up, except for probably Uttarakhand. And the red one may be like Bihar, like that. So still we have a problem with the border, and we epidemiologically what we fear that even if when the lockdown will be relaxed, the problem of influx of the people from our neighbors and also maybe from other countries where our migrant laborers of Nepal are there, we may still have to face a second wave of corona epidemic. Next slide, please. Next slide. Next slide, please. Can you hear me?
Yes, next.
Yes, this one. Okay. So this one shows like in different part of Nepal, just like in that map, and which cases and then how many recovered. So only in recent last week that we have this rise of these cases, and nobody has recovered from there, but it is only a matter of about 7 to 10 days. So next slide, please.
Alex, can you shift to next slide, please?
Okay. So I was trying to give here a sense of the timeline, and I've already said in January 24, we had the first case, then in March 23, we have the second case that came back from France. All these cases were like, who were people coming with the infection inside Nepal. So a student who was studying in France, about 19-year-old student, was the second case. And then many came from UAE and other areas. So the number kept on increasing. And the increased number actually are people coming from outside with already infection. And only one contact tracing was found to be positive. So there are questions whether all the contacts had been contact tracing has been done or not properly, but so far as the government statistics is concerned, that was the one case was found sometimes back. But now with the recent finding of other cases, more contact tracing has also been positive. And so therefore, what happened was that about 2/3 of the 45 people, 2/3 are for people coming from outside, and 1/3 seems to be from contact tracing. Next slide. From 17th April, we have this case, and it has this connection with the Taglib Jamaat faith, which had in this community I found, and many of these people were found to be in the Nizamuddin Delhi congregation, which have entered in Nepal, and therefore in many of the mosques they were staying. There were some Indian citizens also, and the Nepalese were also infected. So right now the hot spot is that district and those communities, which we are trying to track the contact tracing and whether there's any community transmission or not. But so far evidence is not showing a community transmission, but there seems to be a contact, a number of contact tracing may increase in future because still there is result has to come about 30 or 40 samples. The result still has to become. So maybe tomorrow, day after tomorrow, we'll find the actual number of cases. About 60% of total 45 now, it seems that it's related to this faith right now. So the local administration has sealed the areas, and all these high-risk communities are being tracked. Next slide, please. Next slide. Okay, so government has developed this active surveillance system of contacts, and we are using these mobile apps, and volunteers have been mobilized, and even some part the serological survey of the sample of the community people are also being taken in order to find out whether there is any community transmission is taking place or not. Next slide. So I want to come to these issues and challenges that are unique to Nepal, and maybe many are common also. The first thing seems to be that the 80% of the people of the 45 cases seem to be asymptomatic. And therefore, most of the cases are being treated in a very mild case scenario, even those who are isolated and kept in hospitals. So, before I was listening to the presentation before, and most of these clinical trials and things like that. So very few people are being intensively, nobody has gone to an intensive care unit also. So those people who are being taken care in the hospital, they are doing simple supportive therapy. One case, I think they have tried hydroxyquinoline, and but therefore probably that's why, and WHO Solidarity Trial Nepal is not a part of it. But one of the prominent infectious disease expert in Nepal, Dr. Buddha Basnet, has said that Nepal should be a part of this trial also. And the thing that we're facing in Nepal epidemiologically is what could be the R0 and RT of epidemiological transmission rate. So therefore we can have a sense of how the epidemic may progress. Would it be a big curve, or would it be a flattened curve in Nepal? So Many of the experts try to put the figures of Wuhan and the Europe and America and try to project a very grim scenario in Nepal also. But the data now that we're facing do not actually support that kind of speculation. And therefore, it is high time that we need to have a scientific basis to find out what could be the RT, the actual reproduction number. And probably that's where our scientific community can help us to understand properly and see how it may progress. Because without that basis, it's very difficult to decide what should we do about this lockdown. I mean, we have to give a policy feedback to the government to see when it is safer to relax a bit or completely take off the lockdown and things like that. Next slide, please.
While we move to the next slide, I would like to ask Dr. Mahesh that we have already used the time. So it would be great if we could wrap it up quickly. So Dr. Mahesh, please.
Yes, this is my last slide, I think.
Great.
So we have an issue of this rapid diagnostic test and PCR, because the quality of rapid diagnostic test has been questioned also. And like in India, we have this thing, but these tests were approved by China's CDC. So this is one of the issue that we have to be dealt with. And another thing is that there's a huge concern and even phobia and infodemics related to this. So there's one side we have to be alert, but on the other side we have to have this kind of problem, how to motivate our doctors and nurses and the general public also in facing this. So the question of seasonality and whether another season is coming, whether COVID can be a problem for Nepal, even if we pass through this phase, whether that will come or not. And what could be the regional international collaboration? If we have a lower case side, what would be the situation? How can we have more collaboration with the scientists, a sustained one, so that we can have, even if we are protected this time, maybe other time you can be more safer that way. And the fourth is, in general, we are thinking in Nepal, we are becoming more and more conscious that, maybe we are doing something with the nature behavior may not be our correct. And maybe we should have, we have to come out of the anthropocentric view of the nature and more be friendly with it. Thank you very much. And the other slides are just the details of the each cases for the benefits of our scientific community. Thank you so much. Bye.
Thank you, Dr. Mahesh. It was great to enlist the issues and challenges. We can all appreciate that since the diverse regions, but the struggles and the challenges looks very familiar and similar to all of us. So thank you very much. All the presentations were very rich. Now we are moving towards our question and answer sessions.
Yeah, I would like to thank all panelists again, especially our colleagues from Nepal and India and Bangladesh, who provided us with very rich information from their countries, especially the challenges that everyone identified. As Dr. Farah also said, we certainly have common challenges, and one of the attendees has also suggested that we should certainly look at forming a collaborative network, especially to look at common research into public health measures. Because we have left with very limited time, I'm just going to categorize all questions into certain themes. And I think it's best to discuss those themes and the individual questions. If they still remain, people can contact the attendees, and their information would be available through the Global Health Network. So there were at least 6 themes that we have identified. The first is related to the research planning, designing, and its review and approval during an epidemic. I think I can comment briefly on that. The second theme was related to the challenges of ensuring robust public health measures while also respecting the local culture. For this, I would like Dr. Naheed to comment on that in a minute. The third theme was related to the challenges for establishing robust diagnostic techniques, including the use of pooling in testing, and the principles which may govern the development of rapid diagnostic tests, which will enable a greater mass screening in this situation, especially for LMICs. I would put these two questions to Dr. Romina. And then the next theme was related to management issues, the safety of these medications that are being proposed as potential therapies, especially chloroquine in older people with comorbids, as well as development of robust research protocols in such situations when you have limited evidence. And these questions can be put up to Dr. Salma for now. There were some questions related to PPEs. There were questions related to the use of PPEs, but I think a more relevant point that has come up from various comments and questions is also that, and I would request Dr. Mahesh and Dr. Yatin to comment on this, because both of you have pointed out to the issue of the combination of local culture, the shortage of PPEs, as well as its appropriate, fair and rational allocation. So if you can comment on how India and Nepal has addressed this, this would be very useful. And then last but not the least, I think there have been some questions that are related to the development of herd immunity and the role of herd immunity in such settings. I would once again request Dr. Mahesh to comment on that. So while all the panelists collect their thoughts on questions specific to them, I would start off with the questions related to protocol design in outbreak and its approvals. And I would also request my colleague Farah to comment a little bit on ethics approvals. I'm not sure if amongst the attendees, if we have people who are related to the review and approvals process at the regulatory or ethics level, but if there is someone, it would be lovely to hear from them also. I think I mentioned this in my presentation as well, that in an epidemic, there's a need to ensure speed with quality. And as Dr. Yatin also pointed out in his presentation, that WHO covered the speed aspect quite well. But because the situation is rapidly evolving, and so it does in an epidemic, some issues have come up with the solidarity protocol as well. So it is certainly something that one needs to keep in mind, that epidemic research is highly dynamic. It evolves, and there needs to be mechanisms in place which deal with the dynamism of an evolving clinical and public health situation. The second issue is related to ethics and regulatory approval. Many people asked if it is possible to have a rapid review, and yes, it is certainly possible. Many countries across the world have initiated rapid review processes, both at institutional and national levels, as well as at regulatory level. Rapid certainly does not mean compromising the safety of research participants. All it means is that the conduct of research is not delayed via unnecessary regulatory or bureaucratic hurdles. And I think the scientific community as well as the regulatory community has come up together quite remarkably on that aspect. I will let Dr. Farah also comment a little bit on how we handled this. And then we'll move on to our second question, which is related to the second theme of questions, which is related to diagnostics.
Thank you, Mariam. I won't take long, but as Mariam said, we need to have a rapid but robust review system. It seems that the countries and the institutions, they have responded well. They have responded in an active manner. But it seems that following this epidemic or during this epidemic, we have identified the need of more uniform processes which could facilitate, support, and complement the review systems both by regulatory bodies and the institutional review boards. So we would need to have a more standardized operating procedures. And while we are in this epidemic, we too very well appreciate that the things might change, the situations might change, and we would be constantly learning and adapting to the changing situation. So yes, there is a need to work further.
Thank you. I'm told that we also have the chair of the National Bioethics Committee Research Review Board from Pakistan. If I would request Nicole and Alex if they can check if they can enable mic for Dr. Saima Parvez Iqbal. So she can also add her suggestion to this. And meanwhile, I think it would be useful to Dr. Meena, I'll just ask you to hold your thoughts for a second, just to cover the issue, the theme of doing research on the acceptability of public health measures. If Dr. Aliya and Dr. Mahesh could comment briefly about this challenge, this would be great to hear from them.
Mariam, I had a technical difficulty. Can you please repeat your question towards me one more time, please?
So in your presentation, you mentioned the various, cultural issues that Bangladesh has faced regarding the acceptability of quarantine measures and other such public health measures. Dr. Mukesh also alluded to the fact that a certain religious gathering contributed to a huge outbreak in their country. Could you propose, because this points to probably a research gap and the need for community engagement to maybe increase the acceptability of these measures in this situation. Could you comment on both these aspects, the need for community engagement for public health measures, such as quarantine and lockdowns and hand hygiene, as well as possibly what role could research play in this? If both you and Dr. Mukesh could comment a little bit on that.
Thanks, Mariam. So happy to hear the question. This is a very important factor because the culture in South Asia is like living in a family environment, and lockdown or work from home is not a very common concept here. So talking about the community engagement with home quarantine or lockdown situation, one of the things that I found in Bangladesh missing is the real effective communication. So what I have noticed that this communication media have been chosen as the electronic media by television. And so how many, and most people living in urban areas, maybe they have access to that. But what about the rural people where 70% of the population live there? So are they hearing these messages from television? Do they understand the importance? I felt very strongly that these measures could be done in a more effective way if these communications were established at a very local level and using messages using local dialect, because say, for example, putting up posters at the local level and demonstrating that, or audiovisual demonstration at that open place people may have access to. So that kind of community engagement was not possible, particularly in lockdown situation. And number two, there is no effort to do that. So this was one of the challenge area. And I felt very strongly that we need to actually have a qualitative understanding from these people who are at the lockdown situation or quarantine situation, who were able to adhere to that properly and who could not adhere to that to these roles. So we need to understand both the positive and negative sides and understand if was it because of the convenience or was it because of their daily need. They could not confine them. So this is important. And second thing, you just touched a bit about the personal hygiene and other things. You know that these are all behavioral change. It is so difficult to change a behavior of a person. It may take lifetime. So but the fear that we really need to impose on people that if you don't wash your hands, how that the virus actually travels back to your nasopharynx and then affect you. So that kind of discussion never happens. It says you have to wash hands, you have to maintain social distance, and a lot of places people don't even understand what is the social distancing. This is not equated to physical distancing from two persons, and how we can maintain that. So there is lack of understanding how to communicate this message. But I feel very strongly if there are efforts to have engagement at a personal level, either through video or telephone conversation with the common people, engage in community health workers who we have not used. In our South Asia second, we have community health workers. If they are the spokesman in their community, they visit them often. So if they could have talked to the community, that would increase their engagement. And you talking about the last point about the social stigma. I don't know about the other countries, but in Bangladesh, the message went to people in a very fearsome way, because people felt that whenever there is a case, a person identified with a disease, the authority will pick that person up and lock them somewhere. Even the person is picked up to get treatment in the hospital, people don't understand that. And in our setting, going to hospital is the last option for any individual. When they fail any other options for treatment, getting cured for any kind of disease, hospital is the last place to go where all other measures fail. So when there's a strong message, a person, if identified as having COVID, they will be taken to hospital, and people felt that it is a sort of lockdown and they are being taken away from families. And it takes a longer time. I saw in our data that it takes a longer time for resolving the disease period. So altogether, we did not make the right communication. So when we're involved in the law enforcement agency, it case for fear. Probably it is important to maintain at the broader level. But at the local level, individual level, people needed to be discussed and given this assurance and trust building that what is being done. And the third thing that I think it's a research question and also service delivery question, like implementation research question, is we have not didn't try to hear from the people who had COVID experiences that when people are getting really severely ill, when people are recovering quickly, so what measures actually help them to recover, or people who did not contract the disease, what are the measures that should help them to prevent them from getting the disease? This kind of practical experience and evidence needs to be presented to common people to help them believe in the systems that has been placed. I would love Mahesh to respond to the religious aspect, so I don't want to talk about that. Thank you.
Okay. Thank you very much for this. May I respond to it? In Nepal's situation, it seems that the lockdown has been very, very effective. And before lockdown also, there has been series of travel restrictions and other restrictions. And lockdown has been very successful also, bar some of the issues there, some of the shortcomings there. In Nepali culture, it was quite well accepted, even though people have faced a lot of difficulties. And therefore, what we are seeing is that Nepal seems to be poised for a flattening of curve, even without going very high. That is our assumption. The problem we faced in lockdown is actually socio-economic problem. You know, people who were in the lower ladder of society economically, there has been some difficulty in managing their livelihood. And but because Nepal has a federal system, so what happened is that the local government has come to the forefront, and they are taking care of it with the help of the federal government. So even to track the cases and contact the local governments are very, very effective. I mean, cordon sanitaire, all these things are happening quite well in Nepal relatively. So far as the PPE and other concerns. So what happened was that about the awareness, media has played a great role. And there was a time when this safety and security means were not very much available to the healthcare workers. The number, was like all the countries were facing that kind of scarcity. So Nepal also faced. So that was a period when the healthcare workers also were very worried. But what happened was that Nepal made a deal with China and also privately bought from Chinese entrepreneurs. And then when that lot came, that resolved this issues to a large extent. And even now, Nepal is gathering a large consignment of PPEs from outside, but also it is started producing within Nepal. So that part seems to be, handled well. So far as this recent this thing of Muslim community is concerned, in Nepal, as you know, there's a very good harmony, behavior within our communities. There is a great cultural tolerance. So therefore, even though there has been some of there is a suspicion that the disease has been contracted from some religious gathering, but the religious harmony is quite well maintained. The government is very much conscious about that. And the Muslim communities have also come forward, their leaders, and asked to cooperate with the government and see and give them their actual detail, because it is very important for the contact tracing. It is very important to know whether these people infected other people or other people actually infected them. So this is something to be sorted out in near future. That's what I want to say right now. Thank you.
Thank you so much. Thank you both Dr. Aliya and Dr. Mukesh. I think you've raised very interesting points and given us food for thought. There are 3 more themes to cover for us. And because we have now run out of time, I think if we can take quick comments from Dr. Yatin about the challenges associated with allocating scarce resources such as critical care in this situation. That would be helpful. And then I'll take up the last 2 questions with Dr. Romina and Dr. Salma.
Yes, the problem is about the critical care beds and the number of ventilators. Because if the curve does not flatten, we are heading, all of us are heading for a serious trouble. So at the moment, we are handling all right because the rate of increase has, the number of days in which it doubles has doubled. So from 3.2 days where it was doubling, we are now to 8 point some days. So that it has slowed down a little bit. At the moment, we'll be able to handle it. But as I said, Italy has more ICU beds and intensivists than US. And Italy got into so much of trouble. They're ventilating patients on the roadside. So how are we going to cope with it? And ventilators are not some low technology stuff which you can manufacture overnight. PPEs you can. And all 3 countries of ours, all 4 countries of ours have the expertise to make, we are very good with garment manufacturing. Bangladesh is such a big exporter of garments all over this thing. So it's not technically that difficult to start manufacturing the PPEs. There are certain criteria which are required, which is okay. N95 mask is a problem. In US is also a problem. What we have started, at the moment we have adequate numbers. And everyone has started manufacturing it. But N95 masks, what we are using, we've got 10,000 masks in my hospital now. But we are keeping it in case the thing requirement goes up. But there are several studies in the US also where they're reusing it. So we issue it by doctor's nurse's name. There is a system by which it is sterilized and it can be safely used 6 times. So that is what we are doing. They put their number and name on the bag where it is sterilized and it is given back to them. So there is no misuse of the PPEs. And I think if we cope with that, we should be okay. Use it. And I have, for the whole hospital, I have sent the instructions to every staff member of what PPEs to use in which area, because you do not require the full gear for every area of the hospital. If everybody starts wearing it and disposing it off, we all are going to run short. So for specific areas, specific requirements are there, and that is what should be used by everybody. Rest of the PPEs are quite simple. The goggles and the helmet and all is quite simple. It's only the N95 mask which you need to be careful about. Rest are very simple to manufacture, and they are not that expensive. And surprisingly, not only did we get the disease from China, but the first PPEs we got also, they're also from China. So I think they're quite cheap to manage.
Thank you so much. And are there any national guidelines for resource allocation in India, or is this something that is being decided at institutional level?
No, it has been decided. I mean, the government has instructed clearly. They have identified specific areas and specific hospitals which are COVID hospitals.
COVID centers. Okay, great.
Yes, mostly from public health and few from private.
Okay, thank you so much. So I'll move on to my next question, which is to Dr. Rumina. There have been some questions about the use of the pooling strategy and the possibility of exploring rapid diagnostic tests to expand screening. And if you can share, your experience related to that.
All right, thank you, Mariam. So although RT-PCR is a reference standard for COVID testing, but for lower middle income countries, low cost testing is required for mass testing. So antibody test is not perfect, but as said by a scientist, Jeremy, he says, we can't let perfect be enemy of good. So in this case, we can use antibody testing because they have started using that in the West also for screening purposes. At least by doing so, we can screen asymptomatic patients. And by doing that, we can stick to the principle of test, trace, and isolate. We will test the people with antibody testing. If they have antibodies, then we would know that they are asymptomatic patients. And we can then trace people, they might be symptomatic, and we can then isolate them. So we can basically use antibody testing, although it's not perfect, not recommended, but now people have started using this in the West as well as so this is, we can use that in setting like our country. The other question was regarding pooling. So pooling is performed when a lab has many samples, like more than 100 or 500 or 1,000 samples, and that's where we started thinking of pooling. Pooling we had experience because we have nucleic acid amplification testing, NAT testing for blood donors, and we have automation for this system in the lab, where the samples are automatically pooled, and we take a pool of 6 samples. Although I have read papers where they have pooled 60, 30, 64, and many more samples together. But the problem with large pools is that if any one of the pool is reactive or positive for COVID-19 by RT-PCR, then you have to open the pool and perform them individually. So probably that is not, that won't be feasible in our setting. So we have chosen, based on our experience with blood donor NAT testing, we pool 6 samples from patients, and we make, for example, if there are 30 samples, COVID-19 samples, we pool 6, we make 5 pools of 6 samples each. We run PCR on them, the extractions on them. So we save extraction kits. We perform, instead of 30 extractions, we perform 5 extractions plus controls, and then we perform PCR on them. If any one of the pool is reactive or positive, then we have to open that pool. That means we have to run those 6 samples individually. That means we have to start from extractions and do RT-PCR. So pooling is very effective in the labs where the number of samples are high. I have seen that when the number of samples or if the reactivity is high, because when the reactivity is more than 30%, then many pools, they become positive or reactive, and then you have to open them again and redo them all. So it is time consuming, as well as it doesn't save you reagents as well. So pooling is, I think, recommended in the labs where you have high burden of samples.
Okay, thank you so much. So my last question goes to Dr. Salma. There have been many questions around the possibility of herd immunity in the region and what role it might possibly have in the management of this epidemic, as well as the safety of medications, the research around the use of convalescent plasma. So there have been a couple of questions related to, interventions for COVID management. So if you could briefly end by your comments on those.
Sure. So I'll start with herd immunity. So what is herd immunity? The same concept that applies to other infections also applies to COVID. If about 2/3 of your population is infected, you hope that there's enough immunity developed in the community so that when there's another wave of the same infection, those who have not had the infection will be protected by these who have immunity, in a way that when they come in contact with someone who's infected, they will not get it and hence not transmit it to other people. There have been studies done on other coronaviruses, not SARS-CoV-2, of course, because it's a new virus, back in the 70s and 80s, which demonstrated that people remained immune to the previously studied coronaviruses for up to 1 year. So, on one hand, we are propagating social distancing and mitigation strategies, but at the other hand, once there are a sufficient number of people in the community who've had this infection and they've developed immunity, then we get herd immunity. And this is the same concept that applies to other infections. So the second question was about treatment and toxicities. So as I said earlier, none of the treatments that I went over are actually approved for treatment modalities and anti-infectives for COVID-19. It's very important to develop institutional guidelines, as we have done. We also have national guidelines here in Pakistan as far as the treatment of COVID-19 is concerned. Specifically with regards to chloroquine and hydroxychloroquine, one of the reasons that it is being used in this region is ready availability. It's important to note that between chloroquine and hydroxychloroquine is the safer one. The retinal toxicity is, you see that with very high cumulative doses, but the cardiac toxicity can be immediate. And therefore, you need to have a baseline EKG. If someone has a QTc of greater than 500, then we do not use hydroxychloroquine or chloroquine for those patients. For facilities who have the option of telemetry monitoring, should do that for those patients. If not, then you should at least do daily EKGs. At our center, we've not had a very high load of patients yet. We've had 6, 3 in the ICU and 3 on the medicine floor. Of these, we had to stop hydroxychloroquine as they developed bradyarrhythmias and VT. So that's definitely a very important consideration, and these patients need to be monitored. And what was the question for convalescent plasma?
Yeah, so research around the use of convalescent plasma and whether or not this is something that is, logistically practical for countries like Pakistan or other South Asian countries.
So at our center, we have not started to do this yet. This has been started in Pakistan again. As far as I'm aware, at 2 different centers. They are starting trials. They've already procured plasma from patients who've recovered from COVID-19. The rationale to use this is that, this is going to provide passive immunity. It contains antibodies to SARS-CoV-2. So that is the rationale for doing it. During my presentation, I shared that there's not robust evidence for SARS-CoV-2, but this has previously been used for other viruses such as Ebola and MERS. So there's evidence with other infections that this has been helpful. There are case series, small, with very small number of patients. There are case reports. and they have demonstrated benefit. Again, these need to be taken with a grain of salt, because along with the convalescent plasma, these patients also got other therapies like clopidogrel, ritonavir, and interferon. So hypothesis generating, of course, but we need to investigate this further, and Pakistan is also doing this.
Thank you. Thank you for your very insightful answers. I think we can end here with final comment by Dr. Saima Pervez, who has been unmuted for a while now. She's the chair of our National Bioethics Committee, and I think she'll be very well suited to end on a comment on the rapid regulation of outbreak research, how it can be done effectively, and if we have any national research guidelines to guide people. I know that we have recently come across our national guidelines for the clinical ethical issues during COVID. They were launched by the Center of Biomedical Ethics and Culture at SIUT, and also ratified by government bodies. Do we have something similar for research activities? And if you could comment a little bit on the rapid review process. Over to you, Dr. Saima, and then we'll end.
Thank you, Mariam. I hope I'm audible to all of you. Assalamu alaikum and good afternoon. So just quickly wrapping up our experiences with the REC, the National Bioethics Committee, the REC of the NBC. So our main issues that we've been dealing with is that, first of all, you need to realize that Pakistan is not very research productive. So there is a lot of issues with doing research in normal circumstances. So now all of a sudden we are faced with a pandemic, and then we have to rapidly review research proposals coming in from people who are probably not that well acquainted with it. So our biggest challenge was to, first of all, clarifying the science and the methodology. So that was an issue. So because we could not deal with poor science, so we did come up with the rapid review process about a few weeks before we started receiving proposals. This was because we were proactive, our secretariat and the members. We are also members of our institutional IRB, so we are aware that we are going to get a flood of proposals related to COVID-19. We've received about 11 up till now. And after rapidly reviewing them back and forth with the PI as well, we've approved most of them. One of the main issues that we're dealing with is therapeutic misconception, because before the proposal comes to us, it gets onto the media. So there is a lot of media hype. So with relevance to convalescent plasma, to hydroxychloroquine and chloroquine, it's on the media, it comes that, these are promised as treatments rather than, so our public is easily, you can say, fooled. So we have to take this media hype with a pinch of salt, and probably they're giving hope, but, the hype versus hope needs to be, clarified by scientific people beforehand. And so that's our main issue. So maintaining the integrity of the research and keeping it ethical. So we've developed a rapid review process. Within 72 hours, we reply back after reviewing. If we feel that we lack expertise, the committee will co-opt members who are aware. So that is how we are dealing with it.
Okay, great. Thank you so much. And what a perfect way to end this, that research during epidemics is important, but hope must be separated from hype. And I would like to thank everyone, all the panelists and all the attendees who have joined us and who have also patiently sat through this ever-extending webinar. We can finally end, and I think if Alex and Nicole could wrap up with a bit of information on the Global Health Network Corona Hub, we could end there.
Thank you very much, Mariam, and all of our esteemed colleagues in the region. That's been really insightful and a wonderful topic to discuss, both the unique characteristics in your region, plus some of the shared experiences that we're all facing worldwide. So thank you very much to the speakers, panelists, and everyone who's joined via this call and also been following via the stream on Facebook. This recording and many other new sessions will be upcoming, so please do check our Facebook, check the coronavirus hub, which we've set up on the Global Health Network. We've shared links in the chat and both the streams on Facebook. Yes, please do follow us in the future. We really appreciate everyone's time today, and it's been a fantastic session. Thank you very much.
Thank you, Nicole and Alex and everyone who has joined us today.
Thank you very much. We'll begin wrapping up. Thank you so much.
Thank you. Thanks for all the questions. Bye.